but I want to sort of dial it back a little bit and make this more broadly applicable to autoimmune disease. I know many of you on the call today probably have autoimmune diseases, maybe Crohn's and ulcerative colitis, but as you know, autoimmune diseases are really common. We're up to about 100 different autoimmune diseases. They affect 1 in 5 Americans, more than 50 million people, and many people have more than one. So for example, I have a Raynauds phenomena where my fingers turn white because of arterial spasm when it's cold, and I also have eczema. And so, for example, you may have colitis, but maybe also psoriasis, or you may have Crohn's and maybe also rheumatoid arthritis. And autoimmune diseases tend to cluster together. And that's a key, that there's often a common cause, if you will, or a common triggering event that's setting this off, and really a little bit of a clue about what they are. So let's dial it back a little bit and talk about what autoimmune diseases are. Autoimmune diseases really are your body, your immune system mounting a reaction to your body's own normal healthy tissue. So it is seeing your body and your body's tissue as foreign and reacting to it the way it would to an invading pathogen or something that shouldn't be in your body. And we talked last time, or maybe it was the time before, about the Goldilocks immune system. And this is something I want to return to because it's a good basis to think about how these diseases occur. So the Goldilocks immune system means an immune system that is reactive enough to clear the pathogen, be it SARS-CoV-2, tuberculosis, whatever it is, robust enough to mount a response and clear that, but not so active that it overreacts. And now it basically recruits a lot of different immune cells to fight the pathogen, but in the process, it destroys your own tissue, the lungs in the case of acute respiratory distress syndrome, the liver, the heart, etc. So you want to have that Goldilocks immune system strong enough to solve the problem, but not so strong that it hurts your body in the process. When we have an immune system that is not active enough, you run into problems with internal threats, which can basically be problems with cancer surveillance. Then you have an increased risk of cancer or with increased risk of infection. So if you think of a suppressed immune system, internal threat, cancer, external threat, infection, bacteria, viruses, fungal organisms, etc. If we have an overactive immune system, internal threat, reacting to our body's own tissue, that's autoimmune diseases, a whole long list of 100 of them. Maybe actually slightly more than 100 right now. That's internal threat. External threat would be overreaction to triggers in the environment. So that could be pollen, bee stings, wasp stings, etc., peanuts. So a sort of heightened allergic system. So we want that system right in the middle. And clearly something is going very wrong because, 1 in 5 people have an autoimmune disease. So what is it that we're doing that is creating autoimmune disease? So if we go back a little bit to something called the Hygiene Hypothesis. So I want you to raise your hand if you are familiar with the term, the Hygiene Hypothesis. Let's see a show of hands. Yeah, lots of people. Wow, you guys are good. Fantastic. The numbers are still going up. Okay. So for those of you who may not be familiar with the Hygiene Hypothesis, David Strawn is, I'm not sure he's still alive, but an epidemiologist at the London School of Tropical Medicine and Hygiene. And in the 1950s, he was tasked with figuring out why they were seeing skyrocketing rates of autoimmune diseases, 2 in particular, hay fever and eczema. So sort of like allergic asthma and eczema in British children. So he embarked on this 21-year study of over 17,000 children, following them from birth to adulthood. And he found out 2 really surprising things. One is that kids who lived in large families where they were getting coughed on and sneezed on and, sort of trading germs back and forth, lots of childhood illnesses, mild illnesses, they had much lower rates of autoimmune diseases later in life. And the second thing was kids from wealthier families, and back then in the mid part of the 1900s, affluence was associated with more sanitation, more bathing, etc. Not the case now, obviously, but so kids who were from more affluent families where there was generally more hand washing and bathing and so on also had higher rates of autoimmune disease. So this caused us to really rethink this whole concept of, cleanliness as being good for you. And this idea that maybe people were too clean and this is what was happening. And so the Hygiene Hypothesis has been sort of fine-tuned to suggest that your immune system needs a certain amount of exposure to basic pathogens. And, the question of whether you need exposure to other things like measles, mumps, et cetera, is a whole other conversation, but at least a basic thing. So for example, types of coronavirus that cause a common cold, et cetera, you need exposure to that to train your immune system to be able to recognize friend from foe, and to know when to ignore something, when to mount a mild reaction, when to mount a really severe reaction, and rally the troops when you're really under attack. And that lack of exposure, lack of early exposure, particularly in childhood, to enough germs means an immune system that is essentially confused and is now reacting to the body's own normal tissue. In the case of gut immune disorders, what's happening is the immune system is reacting to the normal gut flora. So when you think about it, the immune system has this incredibly complicated job, because remember I told you have this thin lining of the gut, one cell thick, and you have trillions of gut microbes on one side of the lining in your gut. And on the other side, you have all these multiple immune cells, plasma cells, et cetera, that are ready to react. And there's a constant interaction. It's really a hand and glove relationship. There's a constant interaction between the gut bacteria on one side and the immune cells and processes on the other. And so you can imagine that the immune system has to figure out, okay, these trillions of bacteria are just harmless, but this one bacteria or virus is a problem. And how does it figure that out? So there's all this signaling going on. So one example of how that happens is there is a bacteria called Bacteroides fragilis, B. frag. And B. frag is one of the commensal sort of regular gut bacteria that help to signal to immune cells in the wall of the gut lining when there are pathogens around. It actually can recognize, for example, dangerous viruses, and it gives a nudge. It says, hey, time to do something. And it stimulates those immune cells in the lining of the colon to release interferons, and interferons interfere with viruses and mount the attack against the viruses. So, as I explained this, you see that if you don't have sufficient quantities of B. frag and other helpful and essential commensals, that triggering of the immune cells in the wall of the colon is not going to happen. It's going to be disrupted. So, the microbiome is not, technically speaking, the immune system, but it is such an essential part of it. And so what we find for a lot of these autoimmune disorders is that there's a disruption in the microbiome and or a disruption with the gut lining, what many of you would know as leaky gut, an increase in intestinal permeability. So what happens is that the pores in the gut lining that are normally very small, so that only the appropriate small things, fully digested food, et cetera, can get through. Now, when you have big holes in the gut lining because it has been damaged by non-steroidal anti-inflammatory drugs, by infection, by chemicals in food, et cetera, you have these big holes, and now you have incompletely digested food getting through, you have toxins, you have different particles getting through, getting into the bloodstream and triggering an immune response in different parts of the body. So that is one of the mechanisms also for some of these autoimmune disorders. But remember that leaky gut is a mechanism, right? It's a damaged gut lining. And I talk about this a lot. What is in your gut is not actually inside your body. It's in this tunnel that runs the whole length of your torso from your mouth to your anus. And so there's a lot of stuff in the gut that is never supposed to get into the body. It's supposed to get through and come out the other end. But now with the damaged lining, it's getting through and it's triggering your immune system and confusing your immune system. And now you're attacking normal tissue, creating responses. But that being said, I want you to remember that the gut and what's going on in there, as much as I think it's, the cat's meow and the be all end all, it's only one part of the equation, right? You have genetic predisposition, and we know that many autoimmune diseases are genetically predisposed. For example, if we look at Crohn's, we know that the NOD2 gene on chromosome 16 and really hundreds of other what we call susceptibility loci are involved in whether somebody may develop Crohn's. But genetic predisposition on its own typically won't result in disease. You need a trigger. And we know that the environmental trigger for a lot of people is disruption of the microbiome through too many antibiotics, acid blocking drugs, sort of crummy diet, not enough fiber, et cetera, NSAIDs that can disrupt the gut lining. So there are lots of different things that can act as that trigger and set off the immune system. And so we know from genetically identical twin studies that all of these autoimmune diseases, even the ones where there is a genetic predisposition, like with Crohn's, are not 100% genetic diseases. And there are all these other factors that play a role. So I want you to think about that, the role of the gut, but also the environmental triggers. And many of those triggers are things we don't know about yet. There may be things in our environment, chemicals, et cetera. And of course, diet plays a role. So it's sort of like a Venn diagram, right? With genetic predisposition, microbiome, and environmental triggers for why people have autoimmune disease. So let me tell you a little bit about, let me switch to a different liquid, some water. Let me tell you a little bit about our experience in my practice. I don't want to talk for too long today, just because I know you guys have great questions and I want to make sure we get to as many of them as possible. But when I left Georgetown in 2004 and opened my private practice, when I left as full-time faculty, still a voluntary faculty there, and opened my practice at Digestive Center for Wellness, which at the time was called the Digestive Center for Women, I started seeing a lot of inflammatory bowel disease patients. Now, many of them had been my patients at Georgetown and had come with me, but I started seeing a lot of new patients because I think people, the word got out that I was interested in not just prescribing a biologic, not prescribing a biologic at all, actually, but getting people off biologics and looking at other ways we could treat these diseases. And I had a lot of patients come to see me who were on something called a specific carbohydrate diet. So raise your hand if you have heard of SCD, specific carbohydrate diet. So see a show of hands. Lots of people. You guys are a sophisticated crew. I love that. The specific carbohydrate diet was popularized by Elaine Gottschall, but it was actually created a few decades before by a physician who she was seeing for her child. And it is similar, sort of like a first cousin to paleo, right? It is it reduces a lot of processed carbohydrates, and it allows some things. I mean, there's subtle variations between paleo and AIP, the autoimmune protocol, and SCD, et cetera. But what most of them do is they cut down on processed carbohydrates, sugars, et cetera. Some allow dairy, some don't. Some allow legumes, some don't. And we'll get into some of the nitty-gritty of that. But I was seeing a lot of patients on SCD, and a lot of them were coming in already good. They had done the work, they'd done the research, they'd done the work, the diet was working, and they were just coming for validation because typically their gastroenterologist was saying, oh, this is crazy, you need to be on the drugs, food doesn't make a difference, a diet doesn't work, but they were feeling better. So they were coming to me, and I was looking at what they were eating, and I was looking at their colon, I was doing endoscopy, colonoscopy on them, and I was saying to them, yes, your colon is looking as good as you are feeling. This diet is working, keep going. And again, so I can't take credit for putting a lot of these patients on the diet. They actually taught me most of what I know, but this diet clearly worked. So in 2014, with a wonderful nutritionist who was working with me at the time, Jenna Hamshaw, and a couple other people in the office, we decided to do just a retrospective review to really look more formally at some of these patients. So we took 12 patients, 9 with Crohn's, 3 with ulcerative colitis. It was a pretty even male-female split. And we decided to look at some parameters for, how long they'd been on the diet, how long it took for the diet to work, and then look at what was going on in their colon. And we did colonoscopy on 8 of the 12 patients. Some of the others weren't due yet or already had a colonoscopy with someone else. But of the 8 patients we looked at, 6 out of the 8 had what we call mucosal healing, which is sort of the holy grail for IBD, right? It means not just that you feel well, but that your colon is healed. We're not seeing ulceration, we're not seeing inflammation. The colon looks normal. So that is really the highest standard for being able to say that you are in endoscopic remission. And then of course, clinical remission is important too. We want to make sure you're feeling well, but there are instances where people feel well, but the colon still doesn't look good. And that can sometimes be because they have a high threshold, or they're maybe just not noticing, but we definitely want that colon lining to heal, because without that, if there's still ongoing inflammation in the gut lining, in the case of inflammatory bowel disease, that still puts you at risk for colon cancer and other things. So we found, again, complete mucosal healing in 6 out of the 8 patients, and more than half of the patients were able to get off their medication. And these were patients who were on steroids and they were on biologics like Remicade, Humira, et cetera. So this was sort of a big deal. When we looked more specifically at the patients, what we found is the average time for the diet to work was about 30 days. Now, I had a patient, I remember her well, she noticed an improvement in 2 days. And we had patients where it took 3 months or longer, but 30 days was average, which is why in my practice, I typically tell people, give me 90 days. Let's hit this hard for 90 days and see. And I don't necessarily expect that at the end of 90 days, you will be as good as you are ever going to be. But if at the end of 90 days, with really hitting the dietary changes hard, you are not seeing any difference at all, then maybe this is not working for you. And I think that's a really important point, because as much as I wholeheartedly believe in food as medicine, I am drinking my green smoothie, I am not taking Advil, cold and sinus, and I'm trying to get lots of rest, etc. As much as I fervently believe in that, I also realized from taking care of thousands of patients over the years that the success rate for diet is not 100%. And I can tell you exactly what it is, because we signed a data use agreement with United Health Group a couple of years ago for them to anonymize and look at some of our data with our IBD patients. And we looked at data. The initial study of 12 patients, retrospectively, we had, it was like upwards of 90%. But when we look more broadly, and we took 300 random patients with inflammatory bowel disease, we found a success rate of about 80% in terms of being able to get off steroids or biologics or other immunosuppressant drugs like 6-mercaptopurine and get into remission. And 80% is pretty good, because the drugs, the most potent drugs, most of them have a remission rate of just a little south of 50%. And by the way, eating a healthy diet is not going to cause serious infection or cancer or any of those other things. In fact, it will often prevent that. So 80%, high 70s, I think it was 79.8 or something close to that, but about 4 to 5 patients. The other thing I want you to remember is that people who are coming to see me, who are seeking me out, and knowing that I have a reputation for getting people off of the drugs, and knowing that I'm going to ask them to make some serious dietary changes, it's a little bit cherry picking, right? It means that the people who are coming to see me already want to do this. They're already pretty motivated to make those changes. And so if you did this in the general population of autoimmune diseases, of the more than 50 million Americans with autoimmune diseases, you'd probably see a lower rate of success, because some of those people are not going to be as motivated to make those changes, right? The compliance is going to be different. So I've been really fortunate to have a super compliant patient population. And I'll just tell you really quickly, on Monday, I had a call with a patient who has been my patient for about 23 years. And it has taken her 23 years to get to the point where she's interested in exploring diet for her Crohn's. She's a retired professor. And it was literally like the thrill of the year when she told me that she'd been doing SCD, my modified version that I make some changes to it and have people do it, that her Crohn's was actually at a really good place. And not only that, she had told a friend in another state who has relatives, father and son with bad Crohn's, who'd had a lot of surgery, et cetera. And they had started doing the diet and they were feeling fantastic. And so, it's that like tell a friend, right? I also want to point out here that I still prescribe immunosuppressant drugs from time to time. My goal is always not to, but there are circumstances and there are patients who need more than the diet. And the goal is maybe they need this for a short period of time. Maybe we put them on this for a couple months, stabilize things, and then we're able to take it off. So that's always a goal. That's not always a reality. There are some patients who, for whatever reason, maybe the degree of cellular damage is such, the inflammation is so resistant that they do respond to those drugs. So I always tell my patients, keep an open mind. Like, I, even more than you, want you to not be on this drug. And we're going to do everything we can to get you off this drug and maintain you off this drug. But it may be that you need something additional to help you. And I want you to have an open mind, with the goal always being to, let's get off it as quickly as possible. So let's take a look. I think I've chatted for long enough. Let's see what we've got. Hello. Hi. It's good to see you too. Yes, this is recorded, so you could definitely send it. Okay. And then in the Q&A, what causes a leaky gut and can it be healed? So leaky gut can be caused by, let me leave the questions open and just put them to the side here. Leaky gut can be caused by a wide array of things. If you want to find out all the things, you can buy my second book, The Microbiome Solution, but let me go through it quickly with you. So think about it as categories. You have the medicine cabinet. So that would be things like non-steroidal anti-inflammatory drugs, anything with ibuprofen in it. Acid blockers can do that. Steroids can do that. Chemotherapy, etc. So radiation therapy. So the medicine cabinet is a big category. Infection is another category. So we see people, for example, getting traveler's diarrhea or parasitic infections, and that causing damage to the lining of the gut. So previous infection can be another one that does it. Food is another huge one. So if you're eating food that's heavily pesticized and things like glyphosate and so on are getting into your system, artificial sweeteners we know are problematic. And there's a whole array of chemicals that, we don't even know, but generally heavily processed food. There was just an article that came out last week talking about emulsifiers in patients with Crohn's disease, and a lot of the lecithins and emulsifiers. I mean, remember, this is the stuff they use in paint to keep the paint from separating. It is literally the same stuff. I mean, some of the wax they put on the apples is a wax we use on cars. These are industrial, should not be in the food, chemicals. And so we know that highly processed food that tends to have a lot of stabilizers, emulsifiers, et cetera, that those things can be damaging. And there's this article that just came out about the association between these foods and Crohn's disease. We know that the mechanism for some of these other diseases is damage to the gut. So the stuff in food, I mean, if you are careful with food, which basically eating food that doesn't have ingredients, right? Like it's an apple, there's no ingredient label on it. It's rice, there's no ingredient label. That stuff is a really healthy way to approach it, to try and avoid a lot of those food additives and preservatives. So what we eat is another thing. What we drink is another thing. So alcohol, we know, can be disruptive, not just to the microbiome, but can also potentially cause damage to the gut lining. So there are a lot of different categories. So it's important to think about it as a mechanism and a whole wide array of things, not just one thing that causes it, but a lot of it is, what we're ingesting, food and drink. Okay. What are some examples of biologics? So biologics would be, they're advertised. I went in 1998 to a meeting in Amsterdam, to this place called Hoysterdun on the North Sea. And it was the International Organization of Inflammatory Bowel Disease meeting. And they were discussing the results with the first biologic used on gut diseases, which was called at the time infliximab. The brand name is Remicade, but before it even had the name infliximab, at that conference, it was just called CA2. It didn't even have a name yet. It was so new. And they were discussing the results, which were virtually magical, right? In terms of how good this drug was at melting away the ulcers and healing inflammation. And a lot of these drugs are very potent, but unfortunately, excuse me, that potency comes at a price because of the risk. Remember what I told you, Goldilocks immune system, suppress it, internal threat cancer, external threat infection. And that's exactly what we see with these drugs. We see a risk of cancer and we see a risk of serious infection with all of them. But examples would be Remicade, Humira, Stelara. I try and block them out because I don't like to use them. But if you're sitting watching TV, chances are you're seeing at least 2 or 3 ads for biologics within the course of an hour or so, because now we've gone from using them for severe refractory diseases to more widespread indications. So for asthma and for eczema and for somewhat milder indications. Okay, my modified version of SCD, I'm so glad you asked that and you brought me back to what I wanted to tell you about those 12 patients. So we found that the diet was working really well for the 12 patients, but there was a very clear, direct proportionality between the amount of fiber people were eating on SCD versus not. So the people who were interpreting the specific carbohydrate diet as bacon and eggs for breakfast, chicken for lunch, steak for dinner with a few broccoli florets wasn't really moving the needle. Those weren't the ones who were having the mucosal healing. Those weren't the ones who were completely getting off their drugs with sort of minimal effort. And so there's this whole issue of what are you eating? I mean, great that you're excluding the processed carbohydrates and, you're not having croissants and cake and cookies and all of that, but are you eating just animal protein or are you including enough fiber? And this is one of the most important points that I want to make. Initially, when people start increasing their fiber intake, often there is discomfort, particularly if you have a disease like Crohn's and you may have narrowing, et cetera. But just more broadly, there's often gas, sometimes there's fullness, et cetera. it's important, if that's the case, to really mix up how you're consuming the fiber. Blend some in a smoothie, steam and cook some of the vegetables, and gradually increase the amount of raw according to what you can tolerate. But remember that most of these vegetables have poorly absorbed carbohydrates in them. That's indigestible fiber. And for example, raffinose is something that is indigestible by us. It's a major ingredient of beans, for example, of most legumes, and it's broken down by gut bacteria and then fermented to produce those really important short-chain fatty acids. We don't have the enzyme to break down raffinose, alpha-1 galactosidase. You can take it externally in the form of BINO, and that will help with some of the gas. But part of why those fibers are indigestible is because they're not really there to feed us. They're there to feed our gut bacteria, kind of like the human milk oligosaccharide and breast milk. It's not there to feed the baby. It's there to feed the baby's gut bacteria. So poor tolerability. And by that, I don't mean you're like writhing around on the floor with like terrible gas pain, but if you're having a little gas and discomfort, give it some time, do more cooked, gradually ease into it, try some BINO, because that is not necessarily a reflection of whether it's good for you or not. That just has to do more with, you know, your GI tract is filled with fiber and maybe it's uncomfortable. So my modified version of SCD, I ask my patients to really limit or eliminate the dairy, because when Elaine Gottschall wrote the book, the widespread use of antibiotics in the dairy industry was not what it is today. So unless you have a cow or a goat kind of tied up in your backyard, the reality is that most of the milk that we're seeing has been, at some point, the animals have been treated with antibiotics. So it just doesn't really have the same benefit, and you're potentially being exposed to antibiotics if you're doing a lot of it. So I will tell them to limit or avoid dairy. And if they are going to do dairy, stick to the lower lactose products like a hard cheese, like an aged Parmesan would be a good choice for cheese, and not, you know, tons of cheese every day. So that's my main dissection with the SCD, is limiting the dairy. Once my patients are feeling better, I also encourage them to add in some of what I call MACs, I don't call it, that's what they're called, the microbiota accessible carbohydrates. So MACs are things like oats, and really think of it as those complex carb grains, right? So I will have my patients add in, they should already be doing sweet potatoes, squash. I'll have them add in some oats, some raw oats or some cooked oats, some oatmeal, but not instant oats, not anything with all the sugar in it. I'll have them add in a little bit of brown rice, but actual brown rice, not brown rice pasta, not brown rice tortillas, not the processed form, but actual brown rice, and some quinoa. And again, not quinoa chips, because once a food is coming out of the factory in the form of a chip or pasta, as opposed to out of the ground in the form of the actual rice or grain or seed, it's been altered, right? So those are usually the things I will have them add in. And the reason why is because we know those foods are helpful for feeding gut bacteria, for feeding the F. prosnitzii, the Faecalibacterium prosnitzii that ferment the fiber to produce the short chain fatty acids. And so if you go to keto, if you reduce the carbs too much, you end up eating mostly animal protein, you don't get the same effect on the gut. So that's the main modification. Hi, what are your thoughts on if an anti-inflammatory diet can be helpful for people who have atypically severe immune responses to COVID vaccines and boosters? That's such a great question, Ben. Thank you so much for that. You know, the response to the vaccine and booster is also, again, one of these fairly complex questions. I had a terrible reaction to my second shot of my Pfizer vaccine series. I literally thought I was going to die. I had fever, vomiting, headache, chest pain. It was really bad. Fortunately, I recovered. And, you know, I eat a really anti-inflammatory diet. So that was really a surprise to me. And, you know, other people in my close circle who don't eat as well had no reaction. So, you know, it's one of those things, you can't draw a straight line from how you're eating necessarily to response, because there are other things that go on. So for example, people who have autoimmune disease, typically, again, you have an overactive immune system, you're going to make antibodies to different things. So you may make more antibodies more quickly to a vaccine and respond more to that just because of the autoimmune disease, regardless of the diet. And again, diet is a big part of it, but there are other things that can determine how active your autoimmune disease is also, things like stress and sleep, et cetera. Different people have different triggers. So just to make sure I'm getting your question though, Ben, can an anti-inflammatory diet be helpful for people who have atypically severe immune responses to vaccines and boosters? I mean, I would answer that by saying it can't hurt, right? I mean, what's the worst thing that can happen? You eat a super healthy diet for a few weeks or a few months before the vaccine in terms of trying to quiet down, because it sounds like what we're getting at here is there a way to quiet down an exaggerated immune response to a booster or vaccine? And the answer to that is, I don't know, but I don't think it can hurt. And if you guys have been on a couple of these office hours with me before, you know that I'm obsessed with this book, Why We Sleep by Matt Walker. My publishers at Penguin Random House would be saying, no, he's not a Penguin Random House author, but he wrote a great book. He's a neuroscientist. And the information there between sleep and the immune response is bananas. So I mean, this is the opposite to the question you're asking, Ben, but one of the things they found is that the response to vaccinations can be significantly blunted if you're not getting enough sleep in the 2 or 3 days before, right? You can basically not mount a sufficient response to the vaccine. That's the other side of that question. Okay, how does SCD affect liver health and diverticulosis? It's a great question. So it depends again on how you interpret it. If you have, for example, fatty liver disease, what we call non-alcoholic steatohepatosis, which is fat in the liver that's not related to alcohol use, usually related to diet, and you do SCD and you interpret it more as, lots of animal protein, not a lot of fiber, that could potentially make your fatty liver worse. Same thing, we know that diverticulosis, those potholes in the colon that affect half of the population in the US over 50, we know that diverticulosis originates because of a diet that's too high in animal protein and fat and doesn't have sufficient quantities of fiber. So if you do SCD and you cut the fiber weight down, it could make your diverticulosis worse. But there are ways to do it where you're eating abundant amounts of fiber, not just green leafy vegetables, but also think of more cruciferous vegetables, sweet potatoes, etc. So the thing to keep in mind there and monitor is make sure you're getting adequate fiber. And I talk about the 1-2-3 rule: 1 vegetable in the morning, 2 at lunch, 3 at dinner, 6 servings a day. So if you're keeping track of your vegetable consumption, you will probably be okay in terms of liver disease and diverticulosis. Thank you for that. Are there certain drugs a 23-year-old should absolutely avoid? He has not embraced a total diet overhaul yet, since he just got diagnosed in May, but may move that way. He's in medical school, so time's a challenge. Wow. So it would be good to know what the diagnosis is. Is the diagnosis inflammatory bowel disease? It sort of depends, right? It's a long list of autoimmune diseases. So for example, if this is a 23-year-old with MS and he's in medical school and he needs to be functional and he's having mobility issues as a result of the MS, that's a different threshold. So I always think that the willingness to take a drug needs to be based on really what the risk-benefit analysis is, right? So if you're very, very sick and your quality of life is really suffering, you may be willing to take a drug with a little more risk because you have a lot more to gain. If you really have fairly mild disease and symptoms are pretty well controlled, then your risk acceptance should be lower, right? You shouldn't be willing to take a drug that has potentially more harmful side effects because you're really not in that bad shape. So the things that, it's hard to say absolutely avoid because I don't know what the diagnosis is and what his symptoms are. But what I will tell you that you can talk to him about and have him talk to his doctors about, for all these diseases and drugs, it's a pyramid, right? We start at the base and we move up. It's like this. And at the base of the pyramid, the drugs tend to be much better tolerated. So for example, in the IBD world, it's drugs like Azicol, Lialda, versions of something called mesalamine, which is actually an aspirin derivative, but has the opposite effect of aspirin. So that's at the base of the drugs, or what we call the 5-ASA drugs. They're incredibly well tolerated, but they're not super efficacious. Maybe only 30 to 50% of people will really respond well to them. And then as we move up the pyramid, the drugs get more potent, but they also tend to have a worse side effect profile. What we have found in the gastroenterology world, we've gone from a bottom up approach where we start at the base of the pyramid with the stuff that's less potent, but also better tolerated, and we march up. we've started doing top down, in large part because the pharmaceutical industry has encouraged people to do that. They want you to use the most potent drugs as first line. That makes no sense, right? I mean, why would you go to a potent drug when you may be able to have the same result from a less potent drug, which would basically, you know, very mild, if any, side effects. So what I would encourage you to do with this 23-year-old is, you know, continue to think about the diet and really encourage him to think less about what he needs to eliminate and more about what he needs to add in. If you can get him to grab a salad at lunchtime, take it with him, see if something's available at the hospital, that's super helpful. And that can really almost cancel out if he's eating some other stuff that's not so great, right? But you really want to encourage him to have more fiber. So take an apple with him, grab a salad, and then you want to encourage him to have that conversation with his doctor about a bottom-up approach. I want to start with the most basic drug that is the best tolerated with the least side effects and see, because maybe the combination of some diet changes, not the total diet overhaul that you told me he's not doing yet, but maybe some basic diet changes plus a drug that's sort of a good drug might be enough to tip him over to where he's feeling well, right? And he doesn't need to get that sort of top of the pyramid, more potent, but more problematic drug. Okay. Diagnosed with Crohn's in 2013, went on a holistic health journey in 2014. Over the years, my stomach makes loud borborygmi sounds after eating. Are there foods that I need to avoid or include in my diet to stop these noises? Well, first of all, congratulations. I always say this, and I say it in all seriousness. If I got diagnosed with an autoimmune disease, I would probably come to one of my patients for care before I go to one of my colleagues, because I don't want to get put on one of these drugs. So good for you that you went on this holistic health journey. I hope it is working. If the only thing that you have right now are the loud borborygmi sounds after eating, I will tell you that is not a problem, unless you are also having pain and or bloating and or constipation, which could be a sign that you have a narrowing in your bowel, which we can see with Crohn's, and the borborygmi is peristalsis trying to get through a narrowed area. So in the absence of pain, in the absence of bloating, in the absence of constipation, in the absence of weight loss, if you're just having loud peristaltic sounds, that's okay. That's not a problem. And I hope your Crohn's is in remission. Can you heal Hashimoto's from mainly eating a plant-based diet? There have certainly been instances of that, and I direct you to my friend Aviva Romm's really good work, her Adrenal Thyroid Revolution book, and all her other great stuff. I have a couple of her books on the shelf behind me. And, you know, I'm not a thyroid doctor, so I don't really treat people with Hashimoto's disease. I mean, many of the patients I see have Hashimoto's, but it's not my area of expertise. And I know that I certainly have anecdotal experience of people recovering from their Hashimoto's by eating a plant-based diet. And again, what do you have to lose, right? Just, you know, make sure that it is a plant-based diet where you're still getting sufficient quantities of fat through things like avocados and nuts, and you know, maintaining the plant protein. But certainly there's no risk to going plant-based in terms of your general health, right? If you're doing it in a healthy way. So I think it's worth a try. Okay. Is UC an autoimmune disease like Crohn's? Yes, ulcerative colitis is a sister disease to Crohn's. So we have inflammatory bowel disease, IBD, and IBD consists of Crohn's disease that affects any part of the GI tract from the mouth to the anus, but mostly the small intestine, and it affects the full thickness of the bowel wall. And then you have ulcerative colitis that is limited to the colon. It can be just the bottom part of the colon, the rectum, in which case we call it proctitis. It can be left-sided disease, the bottom part of the colon, the rectum and sigmoid. It can be pancolitis, which is most of the colon. And that disease affects only the lining of the colon, only the mucosal layer. It doesn't go all the way through the full thickness of the bowel, but it is a sister disease and it is an autoimmune disease like Crohn's. I will say, to further complicate it, that we have other forms of colitis, like we have infectious colitis, that is not an autoimmune disease caused by infection. So when we say colitis, we typically mean ulcerative colitis, but there are other forms of colitides, if you will, that are not autoimmune. Okay. Does a cleanup for a colonoscopy damage the gut microbiome like antibiotics do? If so, do you recommend still for people on a whole foods plant-based diet with no polyps in history, no symptoms of disorders? If so, how long to come back? So that's a great question. And I have answers for you, having done about 18,000 colonoscopies in my career. Yes, it does damage the microbiome, but in adults, what the studies have found is that the microbiome shifts. somewhat dramatically for about 2 weeks, and then it shifts back. So you can tolerate the bowel prep. It will cause some changes, but your flora and fauna will come back, number one. So I wouldn't use the prep as a reason to not have the colonoscopy, but I would ask your gastroenterologist, like, what's the most gentle prep that you can do? In my practice, I used a Miralax prep, which is an osmotic cathartic, because I found it was the one that was easiest on the gut, but everybody's a little bit different. And I still do recommend a screening colonoscopy, a one-time screening colonoscopy at 45, because we know that even people on a whole foods plant-based diet can still have colonic polyps just on a genetic basis. And we know that colon cancer is the second leading cause of cancer deaths in men and women, in non-smoking men and women. So in women, it's breast first, then colon, and in men, it's prostate, then colon, and ahead of lung cancer in non-smokers. So I would still do it, and about 2 weeks to come back. GastroDoc has recently mentioned the new options in UC drug treatment, such as Zeposia, Ranflex, Inflectra, et cetera. Thoughts? Yeah, they are new, but they are in some ways not so new. So we have multiple sort of variations on a theme for some of these drugs. And again, Jason, it really depends on this cost benefit thing, right? So how bad is your ulcerative colitis, and how much do you have to gain versus how much do you have to lose? And I always say, like, try the diet. And I'm a great believer in the mesalamine products because they've been around for decades. I've even used them in people through pregnancy and had good results. I mean, that's not my habit, but in these particular cases, the drugs are necessary. So the problem with some of the newer drugs is we don't have the post-marketing data. So we have the data from the clinical trials, which always looks great, but the post-marketing data is sort of the real world data. Now we're using it in, large numbers of patients and really getting the feedback. So I would, tend to be a little more biased towards the basic 5-ASAs over the new shiny ones. Love tips for Raynauds, what to do when a finger turns white and how to prevent it. The main thing, Sharon, is stress and cold are the two things for Raynauds. Right? If you have very unilateral Raynauds that only affects one arm or one toe, it's usually more in the upper extremities. So those of you who don't know, Raynauds phenomena, it's named after the French physician who described it, is vasoconstriction, usually in the digits in the fingers, sometimes in the toes where the fingers turn white. And they sometimes can go through different color changes, blue, red, usually with extreme cold or with stress. So it's arterial spasm. So it's essentially the blood supply gets cut off or decreased because of arterial spasm. If you have it unilateral and you're seeing it's only in one hand, only in one finger all the time, you should get that checked out, because sometimes there can be actually a blockage within the artery that's causing that. But if you have the typical Raynauds, avoiding cold, and interestingly, most people tend to struggle with Raynauds more when it's not super cold, like in the fall or in the spring, because in the middle of winter, you typically have your gloves and everything is very warm. So you even though it's cold outside, you are less cold because you're prepared. It's really more fall time before it's really cold, when the temperature changes and you don't have gloves with you and you might run into trouble. I keep a pair of gloves in my car because I have Raynauds, and sometimes I forget and I don't have gloves with me. And the supermarket is the worst for me because the supermarket is always really cold. So sometimes it's September, I'm in the supermarket with gloves on. So avoiding cold. And then, stress is another thing that can cause a spasm. So if you find yourself in a stressful situation, maybe you're rushing to get someplace, do some deep breathing, some, a little bit of guided meditation or something that can help relieve the spasm and potentially open up the blood vessels. Okay. Where can we learn about your version of the SCD diet? That diet is spelled out pretty well in my second book, The Microbiome Solution. And for those of you on the call who have inflammatory bowel disease, primarily the course is for IBD, but it's applicable more broadly. We are launching our first course in January called Drug-Free IBD, Remission Without Immunosuppression. And again, the goal isn't necessarily drug-free, right? But I draw that line in the sand between the 5-ASAs and other drugs that are, moderately helpful and very well tolerated in terms of side effects, and the steroids, the biologics, the immunosuppressive drugs that have more potentially problematic side effects. And the goal is to keep people, from crossing that line in the sand if they can. It's a 4-week course. You can find out more about it on our website, digestivecenterforwellness.com. So it's a 4-week course. that starting at the end of January, you'll get a workbook at the beginning, and then every week you'll get a video and audio lesson from me. And then so you'll get that at the beginning of the week. And then the following week, there will be a Q&A with me. And the goal of that, there won't be any lecturing, because I'm going to send you the lecture ahead of time to watch on your own and to read in the workbook. And then the hourly sessions that we do, and so we'll do every week for a month, are just the Q&A. And you can send answers in ahead of time. It will be a small group. So I want to make sure that people's specific questions about their IBD are getting answered. And I'm really, I cannot wait to launch this course, because helping people with IBD avoid or get off of these drugs is really something that I feel very strongly about. And I think I give very balanced advice, right? It's not like, don't take this drug no matter what, but it's really trying to figure out, are you a good candidate for not being on these drugs? And what does that look like? And then what are the specific tactics for getting off the drug? And so it's exciting to be able to work with people on a small group, on a Zoom, where I can see your faces and get to know you and help with that. Okay, is your green drink as good if drank the next day? Sometimes I make enough for 2 days. I get a lot of this. It's not quite as good, but it's good enough. So a day-old green smoothie, tomorrow, Wednesday, is better than no green smoothie, right? And I just find, like, even sitting here, it just gets really thick. So usually if I'm doing it on the second day, I'll reblend it. I might freshen it up a little bit with a little more coconut water or something, but that's fine. Okay, so somebody made a post about a new study stating how lower bowel microbiome health can be associated with levels of loneliness. I could be wrong about the lower part. Are you aware of any such correlation? And can leaky gut affect the blood-brain barrier? Yeah, so these are such great questions. And, we've learned so much about loneliness during the pandemic, unfortunately. And I don't know the study, so I can't speak to that. But what I can tell you is that there's very clear evidence that our emotional health affects our gut and vice versa. And that is through this whole concept of the enteric nervous system, the second brain in our guts. So we have about 7 times as many nerve cells in our digestive tract as we have in our spinal cord, not as in our brain, but in our spinal cord. And we have bidirectional communication between the gut and the brain through the vagus nerve, the 10th cranial nerve. The majority of the neurotransmitters like serotonin that affect mood are actually made in the gut. So the gut affects the brain through production of neurotransmitters and signaling through these microbes that can affect mood. It can affect not just mood disorders like depression, anxiety, but even has a role in diseases like schizophrenia. And the brain can affect the gut through controlling secretion of digestive enzymes, gut motility, et cetera. So they're in direct communication all the time. So when you think about it, the question really is, where does it start, right? Does a mood disorder, does something like loneliness, which isn't technically a mood disorder, but does something like loneliness start in the brain and then affect the gut and affect the microbiome? Or does it start in the microbiome with disruption there and then affect the brain? I have to give another shout out to another great friend and colleague of mine, Emery Mayer, who wrote, he's a neurogastroenterologist at UCLA, and he's written a couple books. His first was the gut-brain connection and the brain-gut connection, and then he just wrote the gut-immune connection this year. But Emery's work is really fantastic, and I love it because he's not like one of these doctors who's commercial and selling a bunch of stuff. I tend to shy away from those folks, but he has great information. And can leaky gut affect the blood-brain barrier? The blood-brain barrier is a different barrier from the gut barrier, but some of the same things that affect the gut barrier can affect the brain barrier. So for example, diet, alcohol, et cetera. So there is that correlation, there is that relationship. And how do I feel about probiotic pills? It depends what you're trying to treat, but in general, we find that food tends to be a more robust substitution for the average person. So if you're trying to create a healthier microbiome, eliminating certain foods, losing a lot of the sugar, the processed fried foods, alcohol, and increasing the amount of fermented foods that you're eating. And so that could be things like sauerkraut and kimchi, as well as a non-dairy ferments like like a non-dairy kefir. Those things tend to be more helpful than just a probiotic pill. The problem with the probiotics, Aisha, is that there is no regulation about how much bacteria are actually in them and whether the bacteria are alive or not. And it's a very expensive and difficult process to get bacteria to stay alive in a pill or powder form on a shelf, right? Even the refrigerated ones. And so, the problem is that when we test most of these probiotic brands, overwhelmingly, we find the number of colony forming units, which is the number of essentially live bacteria they have, is a fraction of what they claim, and that many of the species are dead, which is why, getting your probiotics from food, like if you eat a food like sauerkraut, when you ferment the cabbage, you create a lot of lactobacillus, and then the cabbage itself is also food for the bacteria. So that tends to be just a more reliable way. We do have particular probiotics we use in particular circumstances. I use a product called Visbiome in my inflammatory bowel disease patients. It's a product that has been very well tested in really dozens of clinical trials for certain conditions, like for pouchitis, when the colon has been removed, for other certain GI diseases. And I have a lot of experience with it. And I don't have any relationship with the company, so I don't sell it. I just recommend it to people. If you have a good colonoscopy with total healing, can you come off your medicine? That is a really good time to think about coming off your medicine. And I always say this too: don't stop your medicine without telling your doctor. Full transparency. Let them know, listen, this is what I'd like to do. I'd like you to be my partner in this. They're probably not going to agree. That's okay. Bring them along. That's how I got here. Patients trusted me to say, this is what I'm doing. And in the beginning, decades ago, I was like, oh, you're doing what? You're stopping your medication? And I used to tell my patients, that's like driving a car with no insurance. It may be fine, but if you get in a crash, you're going to be in trouble, just because I didn't know. So now, a couple thousand patients later, I know really well. I dare say I know better than any other gastroenterologist, because of the amount of inflammatory bowel disease patients I've had the sincere pleasure of taking care of. And I've been helping them, not just with what they're eating, but I'm also looking at their colon. So I'm putting them on the diet, I'm getting feedback from them, but then I'm getting the proof is really in that colonoscopy pudding, and I'm seeing that things are healed. So if you have had total healing on your colonoscopy, that is a great time to explore a food as medicine approach in conjunction with your gastroenterologist. Let them know what you're doing. And you may want to, depending on what you're taking, you may want to sort of gradually ease off stuff as opposed to stopping it altogether. Remember, though, I'm not providing you with medical advice here, just education, okay? All right. Susan, ANCA-negative vasculitis in the lungs from the Bartonella bacteria, and was told at Duke that you have an autoimmune illness. Lungs seem healed now, but the doctors want me to stay on immune suppressant drugs. Yeah. This is just sort of protocol, right? In medicine, we never talk about cure for autoimmune disease. But I think that's just semantics, right? Because we think like, even if somebody's Crohn's or colitis or vasculitis is in a deep remission, that it has a potential to flare up. So I like to think about it as lasting remission, durable remission. If the lungs are healed and you seem to be fine, and I mean, the ANCA may stay positive. And for those of you who don't know, that's a blood test, anti-neutrophilic cytoplasmic antibody. That may stay positive. We have people who are ANCA positive in the general population who don't have any autoimmune disease, right? So if the lungs seem healed and all the tests are looking good and you feel good, I think that would be a reasonable time to talk to the doctors and say, here's what I want to do and here's why. I'd like to start easing off this immunosuppressive medication. Always a good idea to really get a tapering schedule from them. Some autoimmune diseases you can just stop completely. Some immune suppressant drugs you can just stop completely, but others you can't. So for example, steroids, if you were on a pretty good dose of a steroid and you just stop it, you will potentially really run into trouble with adrenal insufficiency, because your adrenal glands that make your body's natural cortisone, natural steroid, those have been suppressed by the prednisone you're taking. And so when you stop it at a high dose, your adrenals haven't had a chance to recover and start making their own cortisol. And so, I think in conjunction with your doctors, but, again, just tell them, this is what I want to do, and I'd like your help. I need you to be my partner in this process. And so having an autoimmune disease forever, again, it's a little bit of a semantic discussion, right? If it's in a deep and lasting remission and you're not having symptoms, so it's essentially gone, can we say you're cured? We can say you're in a deep remission, and that's the same thing, essentially. Okay, I are not really able to get into the role of heavy metals right now with this, because it's a little afield of what we're talking about, but we'll try to get back to that on another one. And you're going to get a survey at the end of this I promise you, it's literally like 3 questions. Was this helpful? Yes or no? And recommendation, was it too scientific? Was it not scientific enough? That's an important one. Yes or no. And then, are there any other topics you'd like? It is literally 3 questions, and it will really help us, because as I've said in the past, my goal is not to just sort of chat and run my mouth for an hour. My goal is to provide information that is really helpful to as many people as possible. And in order to do that, I need to know how I'm doing, right? And should I ratchet it up and make it more sciencey? Should I ratchet it down and make it a little more applicable for a lay audience? So please take a minute to do that survey. And also, like, if you want to hear something on heavy metals, like, recommend that to us so we can put it on the list. Somebody who's been on Pentasa, mesalamine, for 6 years, one period of not using for 3 years as your gut was calm. Since you also had a flare, even on the Pentasa, not sure why you should take it indefinitely. Yeah, that's a really good point. I mean, I always ask the patient, do you think this is helping? Because guess what? You're the one who's in the best position to assess that. And I have patients who will be like, oh yeah, absolutely. If I miss a dose on the weekends, I feel worse. And I have patients who will be like, you know what? I ran out of it for 3 months, didn't notice a difference at all. It is completely possible that the Pentasa is not doing anything for you, in which case it doesn't really make sense to keep taking it, right? But again, have a conversation with your doc about that. What's the best time to take probiotics? With meals, after meals, or before meals? Depends on what the probiotic is. So, for different types of gut bacteria, some of them can actually be enriched by taking it with a meal, some of them not so much. So it depends. I follow the instructions on whatever it is you're taking. Hi, Ben. Can leaky gut heal? Absolutely. Absolutely. Just like you can repair that fishing net, right? But what I want to tell you, Monica, is it's much less about a supplement. I know I am always coming down on the supplements, but it's because I just see such commercialism out there in the health and wellness world, and like, take this supplement and your gut will be healed. And really what heals a leaky gut is recognizing the things that are damaging it, removing those things, whether it's the alcohol, the stuff in food, a medication you're taking, removing those things, and really trying to eat as healthy a diet as possible, right? So there's no point taking a supplement while you're also taking Advil every day, right? That's not going to heal a leaky gut, but absolutely it can heal. And I see that all the time. For MS, I want to shout out another wonderful physician colleague of mine, Terry Walls, Wahls. She wrote the book, The Walls Protocol, and she has her Walls Warriors. Terry's a real deal. She's a doc at the VA in Iowa. She has MS herself. She was wheelchair bound. Now she rides her bike. She is one of the most, as my 6-year-old would say, valid people I know in terms of really, like, legitimately wanting to help, etc. Her diet and my diet are a little bit different. Her diet is a little too animal protein heavy for my patients with IBD, but she's in a different field with MS. So I'd really recommend you check out Terry's work. Any suggestions for a diet for chronic kidney disease, particularly burgers? Again, I wish I could help Gabrielle, but that's a little outside my sphere of expertise. Dietitian with a client who I'm sure has autoimmune leaky gut. She cannot eat beans or whole grains without immediate bloating. She's not eating gluten, dairy, or eggs. Finally decided to eliminate meat. She feels better, but seems stalled. Have you seen this? Any thoughts on what to focus to help her? Yeah, I see this a lot. And actually, my friend Will Bulsiewicz, his book Fiber Fueled, has some good tips in there for how to slowly increase the amount of grains and beans. And I remind people that having gas and bloating after you eat these foods doesn't mean that you're having a reaction to them. That's an issue of tolerability, right? That's kind of like saying, if you haven't been running and then you run 10 miles and your muscles hurt, that you're having a reaction to exercise, like, and you don't tolerate it. Like, not exactly, right? You probably overdid it and you did too much. And if you started slowly and you started maybe with a mile and built up. So I like to use that analogy for the food also. Okay. Copy the SCD. Yeah, you can just Google that. If you have fructose malabsorption, it does not mean you have a damaged gut lining. And it may be, our ability to tolerate fructose, we can tolerate some, but depending on what you're eating, if you're eating packaged foods or anything with sweetener in it, you're probably exceeding that amount that we can tolerate. So I would really start thinking about trying to quantify how much fructose you're having and seeing if you can get that. And I always say, like, eliminate the processed stuff, but hold on to the fructose in the fruit, right? But that doesn't correlate with a damaged gut lining necessarily. Let's see, he has ulcerative colitis. Okay, great. Well, I'm so glad he's in medical school, because I think that people who are themselves dealing with chronic diseases like that can often just have an additional perspective they bring to the medical conversation. So I wish him the best of luck. Fish inflammatory for someone with colitis. What are absolutely no-no foods? Harini, I don't think there are absolutely any no-no foods. I mean, a soda. Soda is a no-no food. Soda is just, chemicals and high fructose corn syrup, and nobody should ever drink soda ever. So I feel pretty confident saying that. There is absolutely no benefit to drinking soda. But short of that, and I tell my patients, like, look, if you absolutely feel like you must have a slice of pizza, have a slice of pizza, but have a big salad after. But I will say that that's not really the case in somebody with active inflammatory bowel disease. So if a patient comes to see me and they have active inflammatory bowel disease and they're trying to get off, a steroid or a biologic or something, there's really no pizza in that equation while I'm trying to get them healed. Once they're healed and in remission, there may be an occasional piece of pizza if they can tolerate it. But when they have really active disease, I talked about like that first 90 days of hitting it hard. That's when we're really trying to exclude the processed carbohydrates that would be in the pizza crust and the dairy, and really focusing on increasing the amount of fibrous foods and healthy fats, et cetera. So, the issue of are there no-no foods really depends on where you are in your colitis journey, if you will. Okay. Thank you, Aisha, that human documentary, that was fun to do. What is the relationship between Sjogren's syndrome and diet, and Hashimoto's and diet? Okay, so Sjogren's and Hashimoto's are both autoimmune diseases. Remember I said these like 100 different autoimmune diseases, and we think they may have a common etiology with not enough exposure to dirt. So for example, if you look at a map of the world, in the more sort of northern hemispheres in Western Europe and North America, et cetera, we see high rates of autoimmune disease. In sub-Saharan Africa, Southeast Asia, we see lower rates. And as those countries get more industrialized and there's more, general antibiotics floating around, processed food, et cetera, we start to see the rates of autoimmune disease rising. It's not a one-on-one correlation. I mean, certainly there are people from Southeast Asia who grew up in rural areas who end up with autoimmune diseases, but it is far less common. So, diet is a big piece of it, but the piece I didn't talk about much today is also about exposure to nature, exposure to soil microbes, et cetera, right? All those other things, the sort of rewilding things that also improve our microbiome. So Sjogren's and Hashimoto's are different, and Sjogren's affects, a lot of the salivary glands, et cetera. And Hashimoto's affects the thyroid. But if the cause of your Sjogren's and Hashimoto's is the same, namely, from a diet point of view, your diet has not been optimized, then optimizing the diet and improving the diet may improve both of them. So that's sort of the correlation. I hope that explains things. What tips or questions are good to ask and find? Well, thank you, Sarah. I think the most important thing with a doctor is just making sure they're open to your own personal philosophy about things, right? And I was advising somebody recently. I said, don't go into the visit saying, under no circumstances am I taking those drugs, no matter what. Go into it saying, look, this is my personal philosophy. I'd like to avoid these drugs because of the potential side effects. I know these drugs can be very helpful in some people, but for me personally, where I am right now in my health journey, I would like to avoid them if at all possible. And then you sort of diffuse this, like, I've drawn this line in the sand and you're on one side and I'm on the other side, right? And made it so that's a conversation, and really enlist their help and say, I know you have maybe a more conventional approach and you use these drugs, but I would really like you to help me on my journey to figure out what's possible. And then you're making it more collegial. And if they're just being a jerk about it, then find somebody else. Okay. Oh my goodness, we've gone over. What effect does aloe have on the gut? Aloe can act as a cathartic and help move things through the gut. You know what? I think there's so many great questions. Hi, Rachel. It's so good to see you. This recording will be on the website. It will be archived. Give us a day or two to get it up there. Yeah, listen, I literally wish I could stay with you guys all day, even though I can't see you. I feel like I'm in such good company. And I just applaud all of you for really asking these questions. These are questions that medical professionals are not asking, right? And you are asking these questions. So keep on asking these questions. I'm committed to being with you every Tuesday, rain or shine, cold or not, maybe on vacation one of these days, doing this from some exotic location. Give us some feedback and, without being overly promotional, do sign up for DF IBD course because it's going to be great. And I really look forward to being able to focus on IBD in a more sort of, in a setting where we can really get into the nitty gritty and just focus on that without the other stuff. And we're going to be providing lots of great information. And again, tell us what more stuff you want to see. And again, just to recap those resources, there was Terry Wall's protocol. There was Aviva Ram, Adrenal Thyroid Revolution. There was Will Bulsiewicz, Fiber Fueled. And there was Gut Immune, it was Brain Gut Connection and Gut Immune Revolution, Mayer's book. Okay. All right. It was so good to be with all of you.